Hi, my name is John Gibbons and I am an osteopath, an author and an international lecturer. And today we're going to run through a very brief hip assessment and then we're going to focus mainly on the treatment side of things. Now, in terms of the hip, especially on females, in my practice at Oxford University, I tend to see a lot of what we call impingement syndromes. And an impingement in terms of a hip is basically what we call a femoral acetabular impingement, and there are three types. One is called a cam lesion, which is by far the most common, and the second is a pincer, and the third is a combination of a cam and a pincer. Now the problem is, once you've got an FAI, and if you've got a cam lesion, then more than likely you will have a acetabular labral tear, and most of the tears happen on the rim of the hip joint, right at the front, and is called the anterior superior part. The downside about the treatment is that we can help it, but because it's a labrum, almost like a meniscus in the knee, if it is torn, then it is what it is. It is a torn piece of cartilage and it's not really going to repair. Most of the time, if a lady, say, is a triathlete and she runs a lot and her hips hurt, then a lot of times she'll probably do a little bit less running. I'm not saying that's an answer to the problem, because it's not, but you might find that the athlete will try to modify what they do to try to reduce the symptoms. Now, in terms of an assessment, this is a very quick assessment. This is called the 90-90 test. And then 0 degrees, 90 degrees, and then this would be 45 degrees of external rotation. Most of the time, this movement tends to be okay. This one is normally the key test. So we normally would internally rotate. And if we internally rotate and it's less than 35, and the patient feels a catch-in anteriorly here, then that could be a sign that we have some form of impingement. If you are a bit older, then it could be a degenerative hip joint. From this test, I would normally go into flexion. The patient can hold if she wants to, and then we can slowly flex towards the same shoulder. And again, if they catch or are blocked, then it could be something like a labral tear that could be limiting the movement. The same to the opposite shoulder. This one is more commonly irritating in the groin if you do have an impingement syndrome. Relax your arms, please. From here, I would probably do the FABER test, as in the flexion, abduction, external rotation. And then if you've got a labral tear, the leg would be limited in how far it will drift out compared to, say, the good side. And then I also do you can call this one the FAIR test. So it's flexion, adduction, internal rotation. And again, that would normally catch in the anterior part here. You can also do the scouer test, coming round. And again, that's a similar sort of test, or the FABER test, where we flex, adduct, and we internally rotate. Now, so that's a very quick assessment. And if it was positive, then I want to maybe focus on treatment. The treatment I tend to do is trying to almost like mobilize the hip. So I start in a circumduction, knowing that this angle is going to cause pain. So I'll probably try to come away from there and come out. So we're almost doing a circular motion in one direction, like in a clockwise sort of direction, and then I'll probably come in and then mobilize it in an anti-clockwise direction here. I have to be careful about coming in this like half area here of a half moon, I call it, because I know it's going to catch. So I'll probably start out just to mobilize. The thing is, the joint is like an engine. We have synovial fluid, and then when we mobilize it, the synovial fluid is obviously secreted from the membrane, and then it heats up the joint. From here, I might do almost like a figure of 8 type of motion. And again, I'm just trying to get the ball moving in the socket. As long as it's not irritating, it's okay. And then I tend to come in and I slowly start to stress the hip in different planes. Plane being flexion with a bit of abduction here. And I'm just slowly taking the leg out. Okay?
Yes, it's a little bit sharp.
Yes, a little bit sharp there. So we have to be careful that we not catch from here. And then we can come out into this plane. We can also work on rotation. Let's say she was a little bit blocked. Then we have a choice. You can either get the patient to push the leg away, which is actually turning the hip in. So this would be internal rotation. This would be a muscle energy technique. And we contract for 10, relax, take a breath. On your out breath, we then slowly externally rotate, improving the external rotation. We can, if we want to, go into an internal rotation, ask your patient to pull this way. So she is externally rotating, activating the external rotators of the hip. After the 10 seconds, we be careful in this one. We can slowly internally rotate to see if we got a little bit more improvement. We can come off 90 and go to about 80, and then we can internally rotate. Sometimes it feels easier for the patient. A few other things I do for the hip joint. One technique is I sit on the foot, arm through, hand on top, hand over and I apply a traction technique. So it's like a little mobilizing. I quite like this technique because we mobilize the hip joint. I never say a number, I just tend to do it till I feel there'll be a change. If I was to write the number down, I'd probably say between 5 and 10. To continue with this motion, I would use a rock-in motion where I turn the leg in and turn the leg out. We can also use this as a soft tissue technique. We can almost like find the ASIS and almost like stabilize on the tensor fasciae lata and rock the leg in. We can spring the ASIS almost in a posterior direction. Squeeze your hand here, then you can almost come round and work into the adductors. So you can just work through the soft tissues. We don't need any oils or creams, we can just work through, and again, working on the IT band. We're not going to lengthen the IT band, but we might assist in changing the tone of it a little bit, especially around the tensor fasciae lata. The long lever technique here, we can almost hold the leg, and if I turn the leg in and I mobilize, this is more for the sacroiliac joint. And if I turn the leg out, which is more for hip, because of the iliofemoral ligament is basically unlocking, and then we can traction here. We can also just sustain and hold that, and just a gentle mobilization. We can also just almost like rocking technique, and we can also internally rotate and externally with traction. And some of those techniques are quite nice. Bending the knee up to 90 degrees here. Excuse my hand. So we can keep low rather than high. We keep low and we apply lateral glide to the hip joint. So again, we just a little sustained pressure. If it's uncomfortable in the leg, a pillow to soften the pressure. And we can just literally, it's like a bear hug, where we can just glide out. So this will improve a gliding laterally. And then one more technique, where the leg is over. And then this one, rather than high, because that doesn't really do anything, we almost want to keep it low, and then we're going to apply like an inferior glide this direction, which is known as caudally. So we're just going to apply pressure here. And again, if it irritates into the mid-thigh, then we are going to use a pillow. You can, from here, almost like laterally glide if you want to, but there's normally pressure in the mid-thigh, or the adductors tend to maybe irritate. So we're gliding inferiorly, we're gliding laterally. There's a few of the techniques I do in my clinic at Oxford. I hope you liked what I showed. Please subscribe, and then you'll get all my videos every time I upload. Thanks for watching.